Hi, my name is Susan Elliott. I'm a nurse practitioner. I work at SLU Geriatrics with Dr. Sanford. I carry a panel of patients in the outpatient setting, and then I also spend most of my time in the post-acute long-term care setting, seeing patients in multiple areas. So nursing homes, SNFs, assisted living, that type of thing. Happy to be here.
Hi, I'm Angela Sanford. I'm an associate professor of geriatric medicine at St. Louis University, and I work with Susan in the nursing home, but I additionally do geriatric consults in the hospital in our inpatient geriatric team, and I have clinic as well. I'm a medical director at a skilled and long-term care facility and at an assisted living, and then also of home health. So we're so happy that you invited us to share. We do the Missouri Echo actually, and have not yet presented. We presented part of this talk for them, but we're glad to present to you guys today. I'll let Susan's going to talk for the first half, and then my slides are at the end.
Okay. So this presentation is on diet downgrades, resident rights, and feeding tube placement in post-acute long-term care. Go ahead with the next slide. So our disclosures are that Dr. Sanford and I both have GWEP grant money supplement in our salaries. We participate in 3 different GWEP grants here at St. Louis University, and I'm happy to do so. Next slide. So the objectives of the talk are to identify the ethical concepts in long-term care facilities regarding dysphagia, therapeutic diets, and feeding tube placement, identify the elements of cognitive capacity in long-term care facilities, how decisions of the medical durable power of attorney, legal guardian, and family, or family of dementia of decapacitated residents can infringe on resident rights, identify types of artificial nutrition, contraindications for feeding tube placement, adverse events associated with feeding tubes, and the legal aspects of changing or withdrawing altered diets or artificial nutrition. Next slide. So Dr. Sanford and I both are part of the Missouri ECHO program. So this is their information slide. Much of the talk that's presented can be tied back to the 4 M's, which is part of the John F.
Hartford.
Thank you, Hartford Foundation and the Institute of Healthcare Improvement. Next slide. So beginning with ethical concepts, we have the non-maleficence, avoiding harm. So in the context of this talk, that would be choosing the safest diet. And often that comes to the medical provider to do so. Beneficence, preventing the harm. So we want a preventative diet. A lot of times in the nursing homes, we don't use a lot of preventative diets because we want people to not lose weight, but that is definitely part. Justice. So fair and equitable treatment, so diet accommodations, and then autonomy, so freely choosing, and we'll see how CMS really has written that into the guidelines, and you can actually be audited and found to be not in compliance if we don't do this. Next slide. So in discussing decisional capacity, people say competency, and competency is decided by the court. So physicians can help to determine a resident's capacity and understanding the medical treatments and make decisions based on the understood risk. So that's it in a nutshell. But you really want to have consistencies between the interviewers, understanding the health status and why the intervention is needed. So can they provide a rationale? Decisions are consistent with past conversations, maybe with family or past visits in the clinic or past visits at the nursing home. And then including family in the decision process, especially the DPOA, if anything is questionable. And remembering that formal testing is not enough. So performing the SLUMS exam and understanding the person's scores in the dementia range isn't enough to say that they don't have capacity to make their needs known. Next slide. So in 2016, CMS actually originated the patient-centered care. The most recent update that I could find is in 2017 here. It's listed in definitions, but it's focusing on the resident at the locus of control and support the resident in making their own choices and having control over their daily lives. So it literally means the resident should be in control of nearly everything in long-term care, even if it goes against medical advice. Next slide. Patient rights, you can find that also in the 2017 manual, the CMS manual, when they come out and audit nursing homes, really putting the focus on dignity and respect, incorporating the preferences into the care plans, individuality in the input, and then basically letting and understanding that any resident can refuse any treatment at any time. And next slide. So an example of this, so a personalized meal, the choice of what the meal should be would be a resident's autonomy, having their preferences in the facility, which are available for choosing, is part of the patient rights. And then controlling the type of diet and the consistency in which it's given is patient-centered care. So we'll get into that further. Next slide. So talking a little bit about liberalized diets. Liberalized diets help people not to lose weight and not to have a functional decline. And that's why they're in 2013, CMS did come out and write a memorandum about how we should accommodate the needs and the preferences and the goals of the patient and give them what they want. Because if it's something that smells good, they can think about it and want it, they're going to eat it. Very limited diets, so your pureed or thickened liquids aren't required, even given the chronic condition of anorexia, weight loss, and dysphagia.
I wanted to ask a question. How many of you do diabetic diets in the nursing home? Or is that an option for any of your residents?
No concentrated sweets is
that's what you call it.
Yeah, no concentrated sweets, but it's not the equivalent of like an ADA, or hospital at all. But most of the places I've been to have a no concentrated sweets option.
What about, I know a lot of times the patients will come from the hospital on a low salt diet or cardiac diet. Does anyone honor that in the nursing home?
Think we
Similar, not really. It's no added salt, I believe is what we call it, where, it's not like a 2 gram sodium limitation by a specific, measurement, but we're not going to add additional salt, or we're going to avoid, additional sodium for that person.
In the nursing home that Susan and I work at, we actually don't have any diets like that. We don't have diabetic diets or concentrated sweet diets or, anything like that. Because it's, I always say I can control their sugars as best as I can. But there's always the patients that, eat ice cream all afternoon and then they check their sugar and it's 400 and they call me, so we don't really do follow any of the diets, and they do always come back from the cardiologist. Why are they not on a low salt diet? But we've just found we have too much weight loss when we start to limit things, and that, in the nursing home, a lot of times we're focused more on quality of life. This is maybe not the time to be super strict on what people can and cannot eat.
Absolutely.
one of our biggest, I'm sorry, go ahead.
No, go ahead.
Well, I was just going to say our biggest challenge is sometimes the family members.
Oh, you're right.
Kept their glucose down this low at home. And then we have birthday parties and everyone's getting a piece of cake and they don't want their loved one to have it.
Yes.
And the way we try to do it is a lot of education, a lot of talking. If all they enjoy now, and this is most of our dementia patients, is, we're going to let them eat, but give them a smaller piece. And most of the families will come around, and we don't really, and Dr. Ross can speak to this too, adhere to real strict glucose control.
You're right.
Yeah.
You're right. Susan and I, this kind of reminds me of a patient we just took care of. She knows who I'm talking about, but the daughter would tell her she couldn't eat. So they would check her sugar. And if her sugar was over 200, the daughter would say, "Mom, you can't have this meal. Your sugar's over 200. So we spent, between the two of us, weeks educating. And she finally went home on hospice. But even on hospice, that was the control, was the sugar level. That was where the daughter was very focused,
Yeah,
so there was a lot of education.
Yeah, we just had one too, a care plan last week and it was in You Admit, and the wife was very insistent, no sweets, but fruits, bananas. And she got upset, I saw a cookie or something that everyone was eating. So my first question to her, even though I knew the answer, because I admitted the patient, is he diabetic? Even though I knew he wasn't, but I just looked at her and I said, and why can't if everyone's having, and again, like you're saying, most families will come around at some point, but you have a few sticklers that get quite upset, but we don't really adhere to any special diets.
We also had a situation I'd never encountered before in the dementia unit. It was a patient that came in as vegan, and that's a very difficult diet to follow in the nursing home. And what we found was that he was trying to grab hamburgers off other people's trays.
He did.
Yeah. And then the wife would come in very upset. Well, he wouldn't have done this. This was not, he chose to be vegan. And so, we had a lot of education there that now he's hungry for hamburgers and we probably should let him eat hamburgers. I know in his lifetime he was vegan, but, with his memory loss, that diet is not his preference at the moment. So that was a very interesting scenario too.
Yeah, she came in and fed him in the end and fed him a vegan diet, whether he wanted it or not. All right, so let's move on to our next slide. So everybody's familiar with F-tags. This is CMS's way of telling you that you didn't pass the audit correctly. And so it's very important to abide by patient-centered care, include them in the care plans, value their input, provide them choices, and let them be in control. So let's go ahead and move to the next slide. So just a quick word on what diet waivers are. In the end, they're unenforceable, and they do harm the patient-provider relationship. They pit one person against another. When the provider or the facility comes in and they want someone to sign the diet waiver so that they can eat their, regular diet instead of their mechanical ground diet, what it does is it undermines trust. So it makes everyone defensive. Go ahead and let's go to the next slide. So what we'll do is discuss some cases. And what I want you to think in advance, and we'll go through 3 cases and we'll discuss them all at the end. I find that when we discuss each one after it happens, sometimes we get off track on the one and we don't have time to finish. So what went right? What went wrong? Were there any resident rights that were affected, or aspects of patient-centered care infringed upon? And think in the terms of what matters and medicines. So next slide. So we have a 72-year-old Black female. She's full code. She's had a stroke in the past. She has some vascular dementia. Her slum score was 13 out of 30. Poor dentition. She had an upcoming appointment to get her teeth removed and be fitted for dentures. She has dysphagia, and she had a recent decline in her swallowing. The speech therapist actually came to me and we discussed the patient. The daughter was very involved when she found out that the diet had been downgraded. And the resident was upset. So she found me at my office and she wanted to know who downgraded her diet. So the resident was able to make her preferences known. She could provide a rationale of why she wanted the food and which food she liked and didn't like. And so we got the speech therapist, she and I, and we went into the room and we talked about what is autonomy and that she's in control of her care, that this is a home-like setting according to the social model of care, and that she could provide input and that she was the boss and that she had the ability to refuse any treatment. We talked to her about what the medical durable power of attorney really was, and that her daughter had the right to step in and make decisions for her only when she couldn't decide for herself. We talked about what dysphagia was, how it worked, the mechanical diet versus the puree diet, and the associated risks up until death, choking and death. So once she actually heard all the information, she decided to change her diet and keep the puree diet and not do the mechanical that she was on, because she was the decision maker at that time. We talked about goals of care. She did decline changing her code status. So she kept it at full code. And we documented everything that went on in the room at that point. Later, she did have her extractions. She got her new dentures. She still had the same problems with swallowing. Even though she could chew a little better, it was not up to snuff. She still opted at that time to move her diet back up to mechanical, even though she had given the puree a try. She could tell me that she wanted to have the mechanical diet because of quality of life. She literally told me that as she sat in the dining room across from people eating real food, that she felt like she was being punished by eating the puree diet, and that she didn't have any appetite. So in the end, she was happy, tolerating her diet very well, and she ate better. So let's move to the next case. So this is an 82-year-old white female. She was a DNR. She had very severe dysphagia. She already had a feeding tube placed, number of hospitalizations for aspiration pneumonia. She had advanced dementia. She asked the nurses every single morning for coffee, so much so that the nurses would come to me and say, she's still asking me for coffee, unrelentingly. So the family was very involved in her care. They wanted to know where to go from now. So they sought out provider input. We counseled on what dysphagia was, the fact that she already had a feeding tube, and the associated risks of drinking the thin liquids, her coffee. And so they agreed at that point that it was worth it for their mom to have increased quality of life and have her coffee. And the code status was changed. We discussed what a full code meant, and that if she wanted to continue to drink the thin liquids, that would mean that you would go out to the hospital if you had an issue. And so they were on board for it all. We had a successful visit. We documented everything in the chart, and she lived very happily with her coffee until COVID-19 caused her death about a year later. So. And next slide. So for our third case, 78-year-old white female, she's full code, she has dysphagia, she's had multiple episodes of aspiration pneumonia, one of which did require hospitalization. She did have dementia. Her slum score was 20 out of 30. She had significant weight loss by the time that this came up. And she had had a diet downgrade, and we had moved her to the puree diet. And the guardian was notified of change, who questioned the need for hospice. So I was actually impressed that the guardian was forward thinking and wondered if we were at that point. We did go to the room, and we did a slums exam. So we knew that the score was accurate at that point. She could provide a rationale for everything. She could say why she didn't like the food. She could say that she had lost weight. She could say that she was unhappy and depressed. So we counseled on dysphagia, mechanical versus a puree diet. What are the risks? We did call back the guardian and let them know that she was able to make her needs known in the room, and that even though she had dementia, it was something that didn't interfere with her communication and understanding of the situation. So the guardian agreed. The diet was upgraded to mechanical. Documentation was put into the chart. Both the speech therapist and I did see her, and she gained weight. She gained weight to the point that she put back on all of her lost weight and then a little, and actually that was good for her frame. So she was doing very well. So let's talk about the cases. Next slide. So thinking about case one, what went right?
And feel free to chat or to chat or unmute, either way.
Yep.
Well, I think one thing I'll say, when we've had people with pureed or whatever, and they hate it, lots of times we're willing to give them a try on a different diet and just see how they do. But I think what went right, just on all the cases, was the communication with the resident and with the family and describing the risk. And I really like the do not hospitalize, because it's so hard to take someone like this to the ER and they sit and they wait, whatever. But I think basically the communication went real well, and giving the person a chance to at least try it, even though, they may have choked to death the first time, but, giving them a chance to try it and telling them the risk and the family the risk.
Think about like how many patients you have at the nursing home with feeding tubes. I thought about this when I was writing these slides. And right now I have one person with a feeding tube. I have 65 patients at the nursing home, and only one person has a feeding tube that they're actually not even using. They're just using for medications. Do you at your facilities have a high percentage of feeding tubes? Or I don't know. It seems like since I started 10 years ago, I've seen a culture shift in this. What about you?
Yeah, definitely. And Holly says 0 in the chat. Very few in our traditional nursing facilities, but our dementia specialty facility that we go to actually has had a policy for years of not admitting individuals with a nursing home, and they're a not-for-profit
That's
nursing
awesome.
facility, focused on comfort care for dementia, basically. So the whole building is cognitive impaired residents, and they do not care for folks with feeding tubes as a what am I trying to say, as a value that they uphold, basically.
And the families know too, they're told at the beginning, their loved ones we do a lot of education like y'all do, quit eating at some point and they're not dying, the body's shutting down, we give the whole education. But I've been there 25 years now, and I think I've only seen 4 people move their ones out in that amount of time because we wouldn't put a feeding tube in. So it's not allowed, and they're just told that.
Yeah, and I think I've used with trainees the choosing wisely sheet about feeding tubes in the setting of dementia specifically. And I definitely think, with that research supporting it, that there's been a shift to avoiding feeding tubes in dementia. And other conditions are a little different, but in dementia, I think that's been a very positive evolution, that there's a lot fewer dementia folks with feeding tubes, at least in my experience. But I have heard from other colleagues that it really varies. So
on the facility,
in certain parts of the country, or among certain groups, there might be more.
We'll talk a little about, one slide's about the characteristics of facilities that have more feeding tubes, but I know I work at St. Louis University, so it's in the city, but my nursing home is in the suburbs. But my colleagues that work in the city do notice they have more feeding tubes than I do. It's just a different patient population, I think, and the values might be a little different. But we can move on to the next slide and we'll get started. So I just kind of wanted to do just a brief overview of the different types of artificial nutrition, just kind of a brief reminder. So it starts with TPN. So that's total parenteral nutrition. This is someone that you would see mostly in the hospital that has a PICC line or a central line where they get it's essentially an infusion of, a big bag of nutrients, essentially. And this is most of the time is meant to be a temporary solution, although some patients are maintained full term. I was at one nursing home before where we did TPN. It was very hard to facilitate in the nursing home. It seemed like it was constantly, the pharmacy hadn't delivered the nutrition or waiting on it. It was hard to get labs to see if electrolytes were maintained, in a proper manner. I found it to be very hard to do outside of the hospital. Has anyone's facility done TPN before? Yeah, it's not good. It's not a good thing. Then there's PPN, so peripheral parenteral nutrition. It's similar to TPN, only it's done through a peripheral vein, and the nutrients are not as dense in the solution, and it's not meant to be a long-term solution at all. So I've seen this done in the hospital. It's still even not recommended. It's one of those situations that has to be a bridge to something. So either getting a PEG tube or, a bridge to something else, or, maybe when someone has a small bowel obstruction, something like that. There's NG, so that's nasogastric feeding. You can do boluses this way or continuous feeding. There's Dobhoff feeding, which usually this is a feeding tube that goes from the nose past the stomach. So the NG tube, the end is in the stomach in the gastric area. And then the Dobhoff is a stiffer tube that you push through the stomach. And usually the goal is to put the end in the duodenum. So you would only do continuous feeds. You can't really do bolus feeds into the duodenum. And then there's the PEG, so that's percutaneous and endoscopic gastronomy tube. That's what we tend to see in the nursing home. And then jejunostomy, so basically same thing, PEG, but it's placed in the jejunum. So those are kind of just the main overview of the different types when we say artificial nutrition. This is the examples. We can move on to the next slide. So what are the indications for feeding tube placement or artificial nutrition? So impaired consciousness, dysphagia. So dysphagia can be either that they can't initiate the swallowing process or that there's an obstruction, maybe in the esophagus, or there's a stricture there, which would be essentially an obstruction or some kind of dysmotility. Maybe there's impaired gastric emptying because of gastroparesis or a gastric outlet obstruction to where you wouldn't be able to feed someone, in a normal way. Or gut malabsorption or malfunction. So I think of this like the patient that's had a lot of bowel surgery and no longer has the bowel function needed to absorb nutrients. Or then maybe sometimes we do it as a short-term bridge in the post-operative period or in the critical illness phase. I think dementia often fits into either the impaired consciousness or the cannot initiate the swallowing process categories here. So with dementia, or I'd say dysphagia because of dementia, it happens because the first part of the swallowing process is voluntarily. So when you put the food in your mouth, it's a voluntary process. You have to initiate, chewing it. You have to think, I'm going to swallow this. Once the food bolus gets back far enough in the mouth, it automatically goes down and that becomes an involuntary process. But the initial chewing and swallowing you have to coordinate some brain function. And with advanced dementia, the brain isn't thinking clear enough to know what to do with the food when it's in the mouth. And so that's why dysphagia occurs with dementia. Next slide, please. So I wanted to talk, you brought up the Choosing Wisely campaign. The Choosing Wisely campaign is a big campaign from the American Geriatric Society. In 2014, they released a paper specifically on their feelings on feeding tube placement. Or feeding tube in advanced dementia, placement. So I wanted to talk a little bit about their position stance. So we can move on to the next slide. So a lot of the following slides are from that position paper statement. So in advanced dementia, feeding tube placement is not recommended, and instead we prefer compassionate or hand feeding. In these patients, tube feeding is associated with agitation. We see more use of chemical and physical restraints, increased development of pressure ulcers, and overall increased healthcare utilization. A lot of times you'll see, patients going to the hospital because the feeding tube comes out. I can't tell you how many calls in the middle of the night when I've been on call for the nursing homes where someone's feeding tube has come out. And of course, it's a Friday night and you're not going to be able to get an appointment with GI till the next week. So there's always the question of what do we do? Send them to the ER or, put a Foley. A lot of times we'll use a Foley as a temporary placeholder to keep the hole open. And often think about once patients get on a feeding tube, they're usually then confined to their chair. Patients that were maybe ambulatory in the past, I know in my nursing home, the few patients we have with feeding tubes are on continuous feeds. So now they're stuck in a chair, basically limited because they need these continuous feeds. So that's when you see an increase in the development of pressure ulcers as well, because you've essentially made them chair bed bound. Next slide, please. So this was a really, really good paper. It's old, but it's on the clinical course of advanced dementia. It was published in the New England Journal of Medicine. I don't think this has scientifically changed in the last 10 years, but it's really normalizing some of these processes that occur at the end stages that families often need education on. So eating difficulties are for sure a normal process in the end, of the end course of advanced dementia, and really should just be seen as part of the normal disease process that occurs. Next slide, please. So patients with advanced dementia often lose the desire to eat or the ability to physically consume food. And this is all, like we said, because of the neurodegenerative process in their brain. And again, eating difficulties are just part of this natural process. In one study that followed those with advanced dementia over 18 months, they found that over 85% of the study cohort experienced eating difficulties. And the 6-month mortality was nearly 50% of the cohort. So this is a common thing that we see, at the end course in stages of advanced dementia. Next slide, please. Eating difficulties, in fact, may mark the shift into the end stages. And I think we must remember in our communication with families that feeding tube placement is a medical therapy. It should be, just considered one option for the management of these end stages. Next slide, please. So this study looked at pneumonia risk in advanced dementia patients who were either receiving hand feeding compared with nasogastric tube feeding. Because I think one of the old models of care, we used to tell families that, maybe feeding tubes would reduce the risk of pneumonia. But we have since done lots of studies and found that this is not actually correct. This is sort of a myth. So this study was conducted in Hong Kong, and it was comprised primarily of nursing home residents. 50% of them had dysphagia, just labeled as medical dysphagia. 33% had behavioral feeding problems. They characterized, patients that weren't able to sit at the table and eat as behavioral. And then 17% had both. And they looked at the incidence of pneumonia in those with advanced dementia. Next slide talks about the results. So there was over 764 enrollees with a pretty older age, mean age of 89. They found no difference in 1-year survival rate. And in fact, the pneumonia rate with those receiving NG feeding was 60% versus those who were receiving compassionate or comfort feeding, as we call it, 48%. So next slide. One of the things that we think what happens or why patients with feeding tubes still have so much aspiration pneumonia risk is if you think of other mechanisms for causing aspiration, it's really that we silently aspirate the contents in our mouth. So once we get to the point where we're not able to swallow food, we're also not able to often swallow, our spit, essentially, or what's in our mouth. And so we aspirate on the bacteria growing in our mouth. And so we're not really fixing the cause of the dysphagia by putting a feeding tube in, and we're not really reducing the risk associated with pneumonia. And also you think of oral care in the nursing home. I know my facility struggles a lot with this, and I think it's worse for patients that are not taking anything by mouth. I think it's a time where we kind of cut corners of, well, they're not eating, they don't need their teeth brushed. And, the stuff that grows in these patients' mouth is pretty rough, I think, if you ever look in their mouth. And you can see why they're developing pneumonia even more so than those that have, dysphagia that we're feeding. Next page, please. Next slide. Okay, next slide. I kind of already said all that. Okay. Go ahead. Just slip. Or in the interest of time, now we're starting to run. I want to get to okay, next one. Next one. We're going to talk about pressure ulcers and feeding tubes. Okay. So this study looked at the role of feeding tubes in the prevention of and healing of pressure ulcers, because one of the other myths is that we would tell families, your loved one has pressure ulcers because their nutrition is so poor. And in order to heal these pressure ulcers, we probably need to put a feeding tube in so we can get better nutrition. Next slide. So what this study actually found was that patients that have PEG tubes and are receiving artificial nutrition are actually more likely to acquire 2.2 times more likely to acquire pressure ulcers. And these pressure ulcers are less likely to heal. And again, like I alluded to before, I think it's because once we put a feeding tube in and we're on continuous feeds, we've really essentially made someone non-ambulatory, and they're actually not moving as much as they did before they had the feeding tube. Next slide, please. So this is an article that was published in JAMA, Journal of American Medical Association, and looks at the patient and facility factors that are most likely to result in feeding tube placement. Next slide. So what they found is that in terms of the actual resident characteristics, so people were more likely to get a feeding tube if they had if they were had a non-white race, if they were of younger age. Males were more likely to have feeding tubes if they were divorced or if they had no advance directive in place, which makes sense. In terms of the facility characteristics, more feeding tubes were seen in for-profit nursing homes in urban areas with over 100 beds, and in facilities that lacked a dementia unit, so probably lacked specialized care in handling end-of-life issues. And then if there was no NP or PA on staff, I think to have some of these conversations. Next slide. So I wanted to take the last bit of the lecture to go over kind of what the position statement is from the American Geriatric Society. This paper was really well written, and they had kind of 5 main points when we're talking to families to consider. So next slide. So the first position statement is that feeding tubes are not recommended for older adults with advanced dementia, and that we instead should offer careful hand feeding for persons with advanced dementia, and that we think this hand feeding is as good as tube feeding for the outcomes of death, aspiration, pneumonia, functional status, and comfort. And instead, tube feedings more associated with agitation, greater use of physical restraints, greater healthcare use due to tube-related complications, and also development of new pressure ulcers. And that the evidence from many studies really suggests that the benefits of tube feeding do not outweigh substantial treatment burdens. Next slide, please. And number 2, efforts to enhance oral feeding by altering the environment and creating individual-centered approaches to feeding should be part of usual care for older adults. So the eating environment is really important. I see this in my dementia unit all the time. The nurse back there that's there constantly knows each person's feeding preferences. And so she knows also the patients that are, most likely to get up, because when we become really demented, a lot of times we lose the ability to focus on a task. So she knows, Marlo's the nurse, she knows that, that one of my patients just gets up and runs. She can only sit for 5 minutes and then she goes and paces. So what she does is orders her hand food. So she sticks, a burger or a chicken sandwich or whatever in her hand. And so the patient can pace and still eat. So having this individualized eating environment where each patient and kind of know their preferences and their trends is really important. For some patients, they need less noise and chaos. I have a couple that have to eat in their room because they're overstimulated with the crowd in the dementia unit. But then I also have some that need the cueing of those around them eating at their table and need the social structure of eating. They look across the table and say, oh, she's eating, I better eat. So knowing kind of each individualized patient's needs are important. Tube feed should not be viewed as an easier or more efficient way of feeding. Feeding takes a long, long time, I know. And nursing home staff really may require special training regarding feeding strategies. Next slide. So the third of the 5 position statements are that tube feeding is a medical therapy, and this can be made by an individual surrogate decision maker. We can accept or decline this recommendation. And usually we need to look at advance directives or previously stated wishes or what we think the individual would want to make this decision. So in 1990, the Supreme Court ruled that artificial feeding was a medical therapy. This was the first time this was ever addressed, in the court system. And so it was ruled this is just a medical therapy like anything else. And it could be started or stopped based on patients' preferences or values. This case actually was the Nancy Cruzan case that happened in Missouri. Next slide. So the fourth statement is that it's the responsibility of all members of the healthcare team caring for residents in the long-term care setting to understand any previously expressed wishes of the individual. So we would hope to find these in a review of advance directives or discussions with surrogate caregivers and incorporate these wishes into the care plan. So the goal for us as healthcare providers is really to have these discussions about the disease process early in the dementia trajectory, so that the patient themselves can make decisions regarding future wishes. And just educating the family on this is something that is very likely to happen if your loved one lives long enough, into this disease process. And then if the patient lacks decision-making capacity, really emphasizing with the family the concept of personal autonomy. And really, what would the patient want, not what does the family want? Because I think that gets blurred oftentimes. And then next. So the last one is that institutions such as hospitals, nursing homes, and other care settings should promote choice. and also endorse shared and informed decision-making and honor these individual preferences. They should not impose any obligations or exert pressure on individuals or providers to start tube feeding. It's really, it should not be regarded again as the only treatment choice, but it can be just an option. And we'd want to employ high quality communication to ensure that families really are making informed treatment choices here. And then next, I wanted to finish off with a case of a patient that I took care of. So this is like one of the hallmark cases for me that was really challenging for a long time. She has since passed, but 77-year-old Persian female. She was a full code with advanced dementia and dysphagia. She had recurrent pneumonia, anemia, DVT, a progressive overall decline. So I've been at my nursing home for 6 years, and 6 years ago, she was there when I started, and she was already contracted. She was already nonverbal, non-ambulatory. So definitely fast stage, 7C or even greater. So already hospice level when I started taking care of her. Her daughter, of course, was a lawyer. The family had hired church members to feed her by hand because they thought the staff wasn't doing it right. And when I say staff not doing it right, the staff were very uncomfortable. They would say she just keeps the food in her mouth. She chokes on it. We feel uncomfortable feeding her. So the family hired the church members. The church members came in with latex gloves and would literally shove the food down her throat. Like their hands would be all the way in her mouth, because like I said, once it got past the voluntary stage of her holding it in her mouth, once they could get it back far enough, she had to swallow it. So she had an inability to maintain hydration and nutrition, and intermittently we'd have to treat her with sub-Q fluids. She was hospitalized once for a fever, hypoxia, and returned with a feeding tube. So she had aspiration pneumonia many times, but that last visit, she came back with a feeding tube. And then after that, she had 3 more hospitalizations in 2 months for recurrent aspiration despite the feeding tube. And she returned with numerous pressure ulcers. They finally did place her on hospice, but it was a very long struggle. She was aspirating everything at that point. We had to run the feeding tube at such a low rate. It wasn't really providing much benefit because she would throw it up. And then also one time, the nurse called me into her room because they said she's bleeding from her gums. We don't know what to do. So I put on the latex gloves. I got out one of the sticks and I was trying to pry her mouth open to see what was bleeding. And it turns out she had so much food packed in her mouth. It was just like around her teeth, and it had irritated all the gums and caused like a gingivitis picture. So her gums were bleeding because this food was just packed in. So I was just cleaning it out with my finger with the stick. And I was like, what are we going to do? And the family just I could never help them see that she was really suffering and that we were making her worse by doing this to her. They just culturally couldn't grasp it. So that was one of the most challenging cases that I had.